All right, let's jump right in. Today we're going to tackle upper gastrointestinal bleeding, or UGIB, and really focus on what our role as pharmacists looks like through the entire patient journey.
So here's our game plan. We'll start with why UGIB is such an emergency, then walk through that crucial initial assessment. After that, we'll split into the two big treatment pathways, non-variceal and variceal bleeds. And finally, we'll land on what is maybe the most important part for us, discharge counseling and long-term care.
Let's start with a number that really frames this whole discussion, 3%. Now, that might not sound like a huge number, but that's the mortality rate for UGIB. And when you think about how common this is, well, it really drives home that this is a true medical emergency, and every decision we make really, really matters.
Okay, first up, UGIB as a medical emergency, and we're going to focus on understanding the two divergent paths this can take. Okay, this is probably one of the most important concepts to get right from the get-go. UGIB isn't just one thing. It splits into two main buckets. You've got non-variceal bleeding. That's about 90% of cases, usually from peptic ulcers. I like to think of this as an acid problem. Then you have variceal bleeding. This is way less common, but it's a whole different beast. It's caused by liver disease and portal hypertension. This is a plumbing problem. And as you can guess, the treatment for an acid problem and a plumbing problem are completely different.
All right, so let's move into Section 2, Assessment and Initial Management. This is all about what happens when the patient first comes in, from the ABCs to risk stratification.
So, what are we trying to do right away? Well, the goals are pretty clear. First things first, you got to resuscitate the patient. We're talking airway, breathing, circulation, the basics. Then we need to prevent any organ damage and get in there with an early endoscopy to treat the lesion. That's where our pharmacotherapy really starts to shine, healing that underlying lesion with PPIs and, the big one, preventing future bleeds.
Now here's a really neat tool. Before they even think about wheeling the patient down for a scope, there's a big question. Does this person need to be admitted, or can they be managed as an outpatient? The Glasgow-Blatchford score, or GBS, is what helps make that call. It's a pre-endoscopy risk assessment tool.
So what goes into this score? It's a mix of things you'd expect. Some lab values like BUN and hemoglobin, and clinical signs like blood pressure and pulse. But here's a key one for us as pharmacists to notice: hepatic disease. See that? It gives the patient 2 points right off the bat. That should immediately set off alarm bells and get you thinking, could this be a variceal bleed?
And the interpretation is pretty straightforward. A low score, say 0 or 1, suggests this is a low-risk situation. Maybe they can be managed as an outpatient. But a high score, a score of 12 or more, yeah, that patient is high risk, and they are definitely getting admitted for some serious intervention. Okay, let's dive into the first pathway, which is by far the most common one. Section 3, treating non-variceal bleeds. And as you'll see, this is the PPI-centric pathway for ulcers.
The management here is pretty much a textbook 4-step process. First, get that early endoscopy done within 24 hours. If they find a high-risk ulcer, they'll treat it right then and there. And then comes our big moment, starting a high-dose IV PPI and running it for a full 72 hours. This is so important. We're not just treating heartburn here. We're raising the stomach's pH to help stabilize the clot and prevent a rebleed. After that 72-hour critical window, then we can switch over to an oral PPI.
And you don't have to take my word for it. Look at this. The evidence is overwhelming. For these high-risk patients, that high-dose PPI infusion significantly reduces rebleeding, the need for surgery, and even mortality. It is absolutely a cornerstone of therapy.
All right, now let's completely switch gears and talk about the other pathway. Section 4, treating variceal bleeds. Remember, this is our plumbing problem, the portal hypertension pathway.
Okay, so the playbook here is totally different. We're hitting this from multiple angles. First, we start a vasoactive drug, like an octreotide IV drip, to bring down that portal pressure. Then, just like before, we do an EGD, but this time they're doing what's called endoscopic variceal ligation, basically putting little rubber bands on the bleeding veins. And here's another huge pharmacy intervention. We have to administer antibiotic prophylaxis, usually something like ceftriaxone. We'll talk more about why in a sec.
And this is such a critical point for us. For any patient with cirrhosis who comes in with a UGIB, antibiotic prophylaxis isn't just a nice-to-have. It is an evidence-based, mortality-reducing part of therapy. We're not waiting for an infection to happen. We're preventing it, and that directly saves lives. This is one of those things we have to be on top of.
Okay, we've stabilized the patients. They're ready to go home.
Now we get to what I think is our most important job. Section 5, discharge and long-term care. These are the key counseling points that can make all the difference. So if it turns out that an H. pylori infection caused the ulcer, just giving a PPI is not enough. You have to get rid of the bacteria for good. And that means a 14-day course of quadruple therapy. And as you can see, we're talking about regimens like PAM-C or PBMT. That's a lot of pills, and that makes our counseling absolutely essential. So when you're counseling this patient, you need to hammer home a few key points. First, they have to complete the full 14-day course. No stopping early just because they feel better. Second, and this is huge, they need to get a follow-up test about a month after they finish to make sure the bug is actually gone. Because if they don't do these things, the chance of that ulcer coming back and bleeding again is incredibly high.
Okay, another big question at discharge is about the PPI. Who needs to be on it for life? There are a couple of key groups. If the ulcer was idiopathic, meaning we don't really know what caused it, they'll need lifelong therapy. Same goes for any patient who absolutely has to stay on aspirin or an NSAID. For them, a PPI for life is non-negotiable. And our job is to make sure that indication is clearly documented everywhere so someone doesn't accidentally stop it later.
And so this really is the final question we need to ask ourselves for every single one of these patients. When they had that bleeding ulcer, do they need a PPI for life? Answering that question and making sure the patient understands the answer is maybe the most important thing we do to prevent them from ever coming back to the hospital with another bleed.